Hello, this is Andy Shorr at the Washington Hospital Center, where I'm the Associate Director for Pulmonary and Critical Care Medicine and an Associate Professor of Medicine at Georgetown University. I want to talk to you about two articles this month, one that was in Chest and one that was in Critical Care Medicine. Both dealt with B-type natriuretic peptide, or BNP, and we're used to using BNP as part of our evaluation of patients with suspected heart failure exacerbations. These studies looked at using BNP in more traditional pulmonary diseases. The first, in Chest, by Stoltz and colleagues, dealt with the use of BNP in acute exacerbations of COPD. COPD exacerbations are a leading reason for admission to the hospital and the ICU, and certainly a leading cause of morbidity and mortality. They looked at measuring BNP on admission to the emergency room and tried to correlate that in terms of the level with the eventual patient outcomes in terms of both need for ICU care and 2-year mortality. In a prospective cohort of approximately 200 patients, they found that the BNP level actually correlated very specifically and very well with the need for ICU admission. It unfortunately performed very poorly at predicting 2-year survival. The authors hypothesized that what the BNP elevation measured was perhaps either occult left ventricular dysfunction complicating the COPD, or pulmonary vascular disease and pulmonary hypertension resulting from hypoxemia. That's biologically plausible because we know in other diseases, such as idiopathic pulmonary artery hypertension, the BNP levels do in fact correlate with outcome. Note that in this study, we are talking about BNP levels in the 50 to 100 range on average. We're not talking about the traditional levels we're used to seeing as elevated up to the 1,000 range when we're dealing with heart failure exacerbations. So this suggests that a simple bedside tool might particularly have discriminatory power at identifying patients at high risk with COPD exacerbations and who might need admission to the intensive care unit. In a complementary article in Critical Care Medicine, a group of authors looked at about 52 patients prospectively undergoing a breathing trial prior to extubation or liberation from the ventilator. They measured the BNP level at the beginning of the SBT, and then they measured it again at the end. About 20% of their 50 patients failed and required reintubation. In the patients who failed, the BNP level actually rose during the breathing trial. They then validated their observations in a second cohort of approximately 50 patients and confirmed that an elevation in the BNP level during the breathing trial was indicative of a patient likely to fail and require reintubation. This observation is intriguing because we've never been able to really identify why patients fail after an SBT. These observations again suggest that either there may be occult left ventricular dysfunction or differential interactions with cardiopulmonary mechanics that could lead to failure that we perhaps don't appreciate as much. The classic example that I see in my ICU is a patient who's on mechanical ventilation, positive pressure is being applied, and they're actually receiving a benefit in terms of both preload and afterload reduction. When that's removed and the patient's going to breathe spontaneously, that resurfaces and they may go into pulmonary edema and fail. I can't always predict that during the breathing trial when they're still on a T-piece or, say, on pressure support. With the BNP, now I might be able to identify those patients early and make interventions prior to extubation. Of course, this study was only 50 patients, even with a follow-on validation cohort, and like the COPD study, it also was small. But these are very thought-provoking ideas to allow us in pulmonary and critical care medicine to make the most of the information we can collect with simple risk stratification tools. So hopefully future confirmatory studies with larger populations and more diverse populations will follow. This is Andy Shorr from Washington, D.C., signing off.